Good afternoon, students. Today's my topic is differential diagnosis of chest pain. And now we're talking about treatment of non-coronarogenic heart disease. And first, we start from the causes of chest pain. We can divide into two big groups. This is the disease of the cardiovascular system and extracardial diseases. If we're talking about disease of the cardiovascular disease, we can divide into coronary disease and non-coronary diseases. Extracardial reasons we can divide into disease of the lungs, pleura, and mediastinum. Diseases of the musculoskeletal system, psychogenic states, disease of the gastrointestinal tract, and other conditions and diseases. Now, diseases of the cardiovascular system, coronary reasons. Ischemic heart disease. It can be stable angina pectoris, unstable angina, myocardial infarction, vasospastic angina, microvascular angina, or systemic vasculitis, pericarditis nodosa, non-specific osteoarteritis. Valvular pathology, aortic stenosis, aortic valvular insufficiency. So all according to include coronary vessels. When coronary vessels not include, this means non-coronary diseases, and this is myocarditis, pericarditis, cardiomyopathy, congenital and acquired heart defects, mitral prolapse, acute rheumatic fever, form dysfunction of the autonomic nervous system. Extracardiac reasons. Disease of the lungs, pleura, and mediastinum. It can be pneumothorax, pleurisy, tuberculosis, tumors, and other diseases involving the pleura, mediastinitis, pulmonary embolism. Disease of the gastrointestinal tract. Esophagitis, esophageal tumors, esophageal spasm, cardiospasm, hernial hernia, stomach ulcer, biliary system disorders, Mallory syndrome. Disease of the musculoskeletal system, osteochondrosis, aniform spondyloarthritis, periarthritis of the left shoulder joint and shoulder arm syndrome, disease of the ribs and the cartilage teeth syndrome, anterior central rib, anterior skeletal muscle syndrome, anterior chest wall syndrome, fibromyositis. Psychogenic conditions, ischemic syndrome, depression, neurosis, cardiophobia, and others such virus like herpes zoster. Now talking about myocarditis. What does mean myocarditis? This is damage of the heart muscle, predominantly of the inflammatory nature, accompanied by its dysfunction and caused by the effects of the infection, parasitic or protozoal invasion, chemical and physical factors, mediated through immune mechanism as well as damage that occurs in allergic autoimmune disease. Myocarditis is a group concept, a group of independent nosological units or manifestation or other diseases. Damage to the myocardium of the inflammatory nature, infection, toxic, including medical, allergic, autoimmune, or unclear etiology, with a wide range of the clinical symptoms from asymptomatic, mild shortness of breath, unexpected chest pain that goes away on its own, to heart failure, cardiogenic shock, life-threatening arrhythmias, and sudden cardiac death. We're talking about etiology, viral causes. The genome of antiviruses, adenovirus, influenza viruses, human herpes virus type 6, Epstein-Barr virus, cardiomyopathy, hepatitis C virus, parvovirus, and can be defined in the endomyocardial biopsy. Bacterial causes. Most often, various types of chlamydia, corynebacterium, diphtheria, Haemophilus influenza, Legionella pneumonia, Mycobacterium tuberculosis, Streptococcus are detected. A feature of bacterial myocarditis is that it is only one of the manifestations of the disease and is secondary to the development of a myocarditis-specific clinic on background of the underlying disease. Direct toxic effect of the myocardium of drugs. A hypertensive reaction to central drugs such as hydrochlorothiazide, furosemide, broad-spectrum penicillins, ampicillin, azithromycin, sulfanilamide, tetracycline, methyldopa, aminophylline, pentane, benzodiazepam, results of eosinophilic myocarditis. The frequency of such myocarditis is low. Non-infection causes of myocarditis include Myocarditis in systemic connective tissue disease with immune disorder and systemic vasculitis, systemic lupus erythematosus, dermatomyositis, polymyositis, systemic sclerosis, systemic scleroderma, rheumatoid arthritis, granulomatosis with polyarthritis, generalized granulomatosis, hypereosinophilic syndrome, helminthic infection, parasitic infection leading to the development of eosinophilic myocarditis. Rare autoimmune and idiopathic myocarditis include recurrent eosinophilic myocarditis, idiopathic giant cell myocarditis, cardiac sarcoidosis. Sarcoidosis is one type of granulomatous myocarditis. Now about terms. Fulminant myocarditis. It's a severe form of inflammatory damage to the myocardium developing rapidly in the form of acute heart failure, cardiogenic shock, or life-threatening cardiac arrhythmias. Subacute myocarditis. The onset of the disease is usually raised. The patient finds it is difficult to determine the chronology of the onset of the disease and the connection with the previous acute infection, respiratory or interstitial disease, but always clearly reports the manifestation of the disease with manifestation of heart failure or pain syndrome, mask of acute coronary syndrome. Chronic acute myocarditis. The onset of the disease remains unnoticed by the patient. When carefully suggestion of the patient does not allow one to detect the duration of the disease. Complaints typical of chronic heart failure dominant. The clinical picture is dominantly by functional class 2nd and 3rd chronic heart failure. Conventional dilated cardiomyopathy often recurs. The typical clinical picture is characterized by a relapse of myocarditis, chronic persistent myocarditis. The onset of the disease remains unnoticed by the patient. It is difficult to speak about the duration of the disease. The clinical picture is dominantly by prolonged pain or clinical manifestation or myocardial remodeling with a dilated or restriction phenotype. Significant dilatation of the heart cavities and the decrease in left ventricular ejection fraction are not observed. The outcome of the disease is variable. Giant cell myocarditis. The onset of the disease is acute. Typically, rapid development of severe circulatory failure with subsequent indeterminate or progression refractory heart failure. The second feature of the clinical picture is persistent ventricular arrhythmias and cardiac condition disturbances. Eosinophilic myocarditis. The onset of the disease is acute. Manifestation of circulatory failure dominant. Most often, acute eosinophilic allergic myocarditis develops while taking sulfonamide group, alticlaglucin, and psychotropic drugs. In pathogenesis, modern ideas about the pathogenesis of the development of myocarditis can be schematically represented in the form of three-phase model. First phase. Attunement of the viruses to the endothelial receptor. The virus replicated and causes myocytes and activation of microRNA synthesis, which is turn lead to apoptosis and necrosis. Second phase. Secondary autoimmune damage to cardiomyocytes. And third phase, developments of myocardial remodeling. Myoclinic classification. A sample and conventional classification of myocarditis were prognosed based on assessment in initial condition of patient. The Mayo Clinic classification, which allows you to determine the prognosis and choice of treatment detectors based on three leading symptoms. This is chest pain, arrhythmia, and manifestation of heart failure. Patients are determined at high risk, moderate risk, and low risk. Then you can see this myoclinic progression. This is we're talking about suspect myocarditis. We can divide patients in three groups: low risk, gray zone, such called gray zone, intermediate risk, and high risk. If it's a patient with low risk, we can see in a clinic chest pain, supraventricular arrhythmias. It can be AV blocks with further left ventricular function. And then we can examine our patient. You can see the algorithm here. Is a patient with so-called gray zone, intermediate risk. It can be persistent, mild, moderate left ventricular dysfunction, persistent regional wall motion anomalies, persistent ACG anomalies, result of LGA, frequent non-structural ventricular arrhythmias without syncope. And the patient with high risk, this is a decompensated heart failure, severe left ventricular dysfunction, life-threatening arrhythmias with or without left ventricular dysfunction, ventricular AV blocked with left ventricular dysfunction. And here you can see the algorithm. It depends on this risk. What you can do with the patient. In these cases, if it's with high risk or with gray zone risk, the gold standard of diagnosis and the myocardial biopsy, and then according to situation. Clinical variant myocarditis. It can be low symptomatic variants, is with minimal clinical manifestations, without clinical manifestation. Pseudocoronary events is a patient present pain in the heart rate changes on the ECG. Pseudovalvular. It's related by diagnosed auscultatory pattern. It can be intense systolic movement, the apex of the heart, polyarteralgia, circulatory failure. Arrhythmic variant, various heart rhythm disturbance, cardialgia. Thromboembolic variant, present by thromboembolic complications, cardiomegaly, and severe heart failure. Decompensated variant, total treatment-resistant heart failure, cardiomegaly, severe heart rhythm disturbances. And mixed variant, a combination of symptoms or different variants. So it's 7 clinical variants of myocarditis. In the debut of myocarditis can be feeling of lack of air, about 70% of cases, pain in the chest area, palpitation, fever, breathing disturbances, emesis, cough, asthma attack, dizziness, syncope, and arthalgia. So you can see the prevalence here, that's a feeling lack of air. Second, this pain of the heart, and so this palpitation. And then you can think about myocarditis according to these clinical signs. Diagnostic criteria for clinical suspected myocarditis. In clinical presentation, we can see acute chest pain, pericardiac or pseudoischemic, new onset. Days up to 3 months or worsened off. There's no rest or exercise, fatigue, with or without left or right heart failure signs. Subacute or chronic more than 3 months or worsening off. There's no rest, exercise, or fatigue with or without left or right left heart failure signs, palpitation, or an unexplained arrhythmia syndrome with or without syncope or body sudden cardiac death, and explained cardiogenic shock. Next, ACG, Holter stress test features. Neuroabnormal 12 leading ECG on a Holter stress testing any of the following: first, from first to third degree antiventricular block, or bundle branch block, supraventricular ventricular valve changes, sinus arrest, ventricular tachycardia, or fibrillation and assisted atrial fibrillation, reduced airway fade, intraventricular conduction delay, abnormal Q waves, low voltage, frequent pulmonary beats, supraventricular tachycardia. Next criteria: myocardial sites markers elevated, and the main of them is troponin. Next, functional and structural abnormalities on cardiac imaging. Echoangiography, SMR. New or rise and unexplained left ventricular, right ventricular structure and functional abnormalities. Regional wall motion or global systemic or diastolic functional abnormality, with or without ventricular dilatation, with or without increased volatileness, with or without pericardial infusion, with or without endocardial thrombi. Tissue characterized by CMR. Oedema, OLG classification, myocardial pattern. Clinical suspected myocarditis if more or equal one clinical presentation and one diagnostic criteria from different categories in the absence. First, this angiography clinical detected coronary artery disease. Coronary stenosis more equal 50%. Second, no pre-existing cardiovascular diseases or extracardiac causes that could explain this syndrome, valve disease, congenital heart disease, hyperthyroidism, for example. A conclusion in there with high number all of data criteria. Is the patient symptomatic more or equal to criteria diagnostic criteria should be met. Magnetic resonance imaging. MRI. The heart is currently the most common information node invasive instrumental method for diagnostic myocarditis. The study protocol for patients with acute myocarditis should include pre- and post-gadolinium T1 weighted images. Complete studies of magnetic resonance imaging and endomyocardial biopsy data have shown that MRI is currently the most appropriate and accurate imaging method for inflammatory myocardial disease associated with high risk sensitivity and specificity. The gold standard for diagnosed myocarditis is subneurocardial biopsy. Morphologically confirmed of myocarditis inflammatory infiltration on the myocardium with necrosis or generation of duvet cardiomyocyte with a not characteristic or ischemic heart disease. Treatment of myocarditis. In a patient present with mild symptoms and minimal ventricular dysfunction, myocarditis often resolves spontaneously without specific treatment. In up of 30% of cases, MRI protein myocarditis can prognose to dilated cardiomyopathy and is associated with a poor prognosis. Prognosis in myocarditis patient varies according to the underlying etiology. The treatment of many forms of myocarditis is symptomatic, but immunohistochemistry and molecular biological analysis on the candle biopsy as well as antibody serum testing is important to find those patients in whom specific therapy is appropriate. It exists in non-drug and drug therapy. Non-drug therapy includes therapeutic regime, bed, semi-bed, hypoallergic diet. Drug treatment include etitropic, if it's a bacteria, the antibacterial drugs for 10-15 days, autoimmunocanalized gilbequinil, NSAIDs, glucocorticosteroids, antiplatelet agents, anticoagulants, metabolic therapy, and spa treatment dispensary observation. Pericarditis. Next, our disease. Pericarditis is syndrome caused by inflammation, acute or chronic, of the pericardium, results in the increase in the normal volume of fluid separately in the heart. It may be associated with pericardial effusion that can result in impaired cardiac filling tamponade. The disease can be an isolated form or a cardiac manifestation of systemic disorder, autoimmune or autoimmune disease. Pericarditis may result from infections and non-infection causes, also it is often idiopathic. Pericarditis is inflammatory in the serum membrane of the heart. According to the clinical and morphological clinics, there are acute pericarditis, subacute and chronic. Acute up to 6 weeks. It can be dry fibrinous and diffusion exudative, with or without cardiac tamponade. Subacute pericarditis from 3 weeks to 3 months. It can be effusion exudative, exudative adhesive, constructive and non-constructive. Chronic pericarditis more than 3 months. Exudative adhesive and adhesive, constructive and non-constructive. According to etiology, pericarditis we can divide into infection and non-infection pericarditis. Infection pericarditis caused by bacterial, viral, fungal, for parasites and other infections. For non-infection pericarditis, the reason metabolic, it's patient with uremia, myxedema, allergic with acute rheumatic fever, systemic connective tissue disease, serum taking, drug-reduced pericarditis, pericarditis treated with heart damage, Dressler syndrome, it's after myocardial infarction, post-pericarditis syndrome after cardiac injury. Any case of acute myocardial infarction when explosive physical factors, traumatic radiation, and for neoplasm, primary tumors, and metastasis in the pericardium. Diagnosis. Based on the current European Society of Cardiology guidelines, at least 2 or 4 criteria are needed for diagnosis of acute pericarditis. First, best chance, second, pericardial rupture, third, ACG changes for new or worsening pericardial infusion. Elevation of inflammatory markers, C-reactive protein, erythrocyte synthesis rate, and white blood cell count elevation, and evidence of pericardial inflammation by an imaging test and CT scan or cardiac magnetic resonance may help the diagnosis and the monitoring of disease activity. This is ECG changes in acute pericarditis. You can see four stages. First stage is ST segment elevation. Second stage, early and late. You can see the dew points of the baseline before T waves being deflected. And then third stage, the T wave inversion, and the last stage, normalization of ECG. PR segment depression with ST segment elevation are rather specific for pericarditis, but up to 40% of the patient present atypical and not diagnostic changes. ECG modification can be diffuse or localized, with TP depression possibly being the only sign. Clinical picture of pericarditis. We can divide it into groups: acute fibrinosis, acute exudative pericarditis. Acute fibrinosis. Pain in a heart area of various nature of intensity, periodical friction noise. The ST segment dries, the T wave is high, and both the ST segment return to is line and T wave inflated. The segment remains on the is line T wave inversion and the ECG returns to normal. For acute exudative pericarditis, at fourth position of the patient, dull pain in the heart area, shortness of breath, tachycardia. On ECG, changes in the position of the electrical axis of the heart to horizontal, decreased voltage, low voltage of ECG complex. The T wave is not changed, isolation of infusion of ECG. Chronic adhesive without cardiac compression. Weakness, increased fatigue, pain in the heart area during exercise, pericardial fraction rate. Echocardiography reveal thickening of the pericardium and pericardial layers, antepercardial and lower pericardial lesions. Chronic excessive without compression of the heart, constructive. Acute cyanosis, weakness, increasing fatigue, poor physical tolerance, pain in the right hypochondrium, enlarged liver, puffiness of the face, swelling of the neck veins. The ECG shows a decrease of the voltage of ECG complex, smoothness of the inversion of the T wave, signs of hypertrophy and overload in the atria, and changes in the electrical axis of the heart to the ventricular only. Echo CG reveals thickening and adhesion of the epi and pericardial layers. Treatment of pericarditis include non-drug therapy and drug therapy. Non-drug therapy is a therapeutic regime, bed, semi-bed, with limitation of physical activity. Drug treatment include etitropic, is pathogen is no antibiotic therapy, connecting the treatment of the systemic disease, neoplasm, etc. NSAID, glucocorticosteroids, colchicine, drugs that moderate increased vascular permeability, ascorbinic acid, vitamin C, calcium, this additional therapy, and dispensary observation. Here in this scheme, you can see treatment for acute and recurrent pericardial and their complications. Pericarditis, acute pericarditis, aspirin, ibuprofen, colchicine. Recurrent pericarditis, NSAIDs such as aspirin, ibuprofen, indomethacin, colchicine, prednisolone, anakinra, and even neurological drugs. You can use azathioprine, methotrexate. If it's a tamponade, it's pericardial synthesis, pericardial window, and constructive pericarditis, active inflammation. Yes, this anti-inflammatory therapy is no pericardiectomy. This is meant for treatment for pericarditis. Now, some words about acute rheumatic fever. This is a post-infectious complication of tonsillitis or pharyngeal caused by beta-hemolytic streptococcus group A, in the form of the systemic inflammatory disease of connective tissue with predominant localization of the cardiovascular system. It's called carditis. It's mean valvulitis, inflammation of the valvule of the heart. Joints, migratory polyarthritis. Its main migratory is due to happen in one joint, tomorrow in another. It's specific more developed big joints. Brain, it's chorea, and skin, erythema annual, and rheumatic fever nodules. Clinical variants: acute rheumatic fever, recurrent rheumatic fever. Outcomes of acute rheumatic fever: recovery, rheumatic heart disease without heart disease, orphan of a heart disease. Clinical picture of acute rheumatic fever. Carditis with damage to the mitral aortic and less commonly tricuspid valves, manifested by orthopneual shortness of breath, corresponding organic cardiac murmur. Rheumatic arthritis is migratory polyarthritis of abdominal in medium-sized joints, knee, ankles, elbows, shoulders, and wrists. Rheumatic chorea, kyberkinetic, muscular dystonia, static, and coordinal disorder, vascular dystonia, and emotional disorders. Annular erythema is represented by migratory pale pink ring jab raised up to 5-10 centimeters in diameter, locus of the trunk or proximal limbs. Subcutaneous rheumatic nodules are round, dense, inactivated, painless formation of various size of the extended surface of the joints in the area of ankles and heel tendons. So you can see the diagnostic criteria, large and small criteria. Large criteria is the first, it's main, it's carditis. Then polyarthritis, chorea, as is known as sound, which dance, a disorder produced by rapid, uncoordinated jerking movements, primarily affected by face, hands, and feet. Fourth, ring jab erythema and subcutaneous rheumatic nodules. Small criteria, clinical, scalability or fever. Laboratory testing, increase ESR, increased selective protein, prolongation of the PQ interval on the ECG, signs of mitral aortic regurgitation of echocardiography. Data confirm previous beta hemolytic streptococcus group A. This positive beta hemolytic streptococcus group A culture, related with the throughout increasing titer of anti-streptococcal antibodies, anti-streptolizin O. Treatment. Principle of treatment of acute rheumatic fever. Eradication of group A beta hemolytic streptococcus. Suppression of the activity in the inflammatory process. Prevention of the formation of the rheumatic heart defect. Compensation of the congestive heart failure in a patient with rheumatic heart disease. Non-drug therapy include bed and some bed rest during the first 3 weeks of the week with a diet limited salt and carbohydrates, rich in protein, vitamins, and potassium. Atopic therapy. It includes penicillin preparation, intramuscular. It depends on the type of the drug. If the patient has allergic reaction to penicillin, we can use macrolides, such as azithromycin, for example. Anti-inflammatory therapy include glucocorticosteroids and NSAID, such as diclofenac. Symptomatic therapy: potassium, magnesium, aspartate, isoniazid monophosphate, trimetazidine, this additional drug. A set of rehabilitation measures, physiotherapy, its additional measures. So thank you for your attention. See you in our classes. Good luck.